All right, let's set the stage. This lecture kicks off our discussion of endocrine gland disorders, which, unlike many things you see in histology, aren't always obvious just by looking at a slide. Endocrine pathology is sneaky. A gland could look relatively normal under the microscope, yet the patient can be profoundly ill because of the hormone output is wrong. Too much, too little, or completely unregulated. As histotechnologists, your role is especially important here because subtle architectural changes, cell population shifts, or loss of normal landmarks can explain a very real clinical disease. Think of this chapter as connecting structure to hormone to the systemic effect. That connection is what clinicians care about and what pathologists rely on you to help reveal. Slide is your endocrine map. If you zoom out, the endocrine system is really just a group of specialized glands that talk to the rest of the body using hormones instead of the nerves. Some glands are obvious, like the thyroid, adrenal, pancreas, and pituitary. Others, like the ovaries and testes, wear two hats, endocrine and reproductive. What's important here is that endocrine glands don't act alone. They release hormones into the bloodstream, and those hormones act on target tissues, sometimes very far away. Histology tie-in: most endocrine glands are highly vascular. If you don't see capillaries everywhere on a slide, you should already be suspicious. Some worthless but fun facts: endocrine glands don't use ducts, so technically they're all ductless divas of the body. This is one of the most important diagrams in the entire course. If this makes sense, everything else falls into place. The hypothalamus is the boss. It senses what's going on in the body and sends signals to the pituitary. The pituitary then sends orders to the peripheral endocrine glands. Think of this like a corporate chain of command. The hypothalamus is the CEO, the pituitary is the middle management, and then the thyroid, adrenal, gonads are the employees doing the actual work. Feedback is the key concept here. When enough hormone is produced, it feeds back to shut down further release. When feedback fails, disease happens. Histology tie-in here is that the anterior pituitary and the posterior pituitary are not the same tissue. One is glandular epithelium, the other is basically modified neural tissue. That matters a lot. Now we zoom in on the anterior pituitary, which is responsible for most of the endocrine chaos we'll talk about later. Each hormone comes from a specific cell type, and yes, pathologists really do care about that. For example, ACTH comes from corticotrophs and targets the adrenal cortex. TSH comes from thyrotrophs and targets the thyroid. Growth hormones comes from somatotrophs and affects basically everything. From a histology standpoint, pituitary adenomas often represent an overgrowth of one cell population. That's why immunohistochemistry becomes so important, because H&E alone may not tell the whole story. So, translation: if you can identify which hormone is being overproduced, you can often predict the patient's symptoms. Slide finishes the lineup and introduces hormones you'll hear about constantly in clinical practice. Prolactin is a big one, literally and figuratively. Prolactomas are the most common pituitary adenomas, and they often present with reproductive systems rather than mass effects. FSH and LH regulate reproduction, but clinically they're often underappreciated because their symptoms are subtle or attributed to normal aging. You'll also notice MSH here. It doesn't get much attention, but it explains why some endocrine disorders cause unexpected skin pigmentation changes. And finally, a reminder: the posterior pituitary hormones, ADH and oxytocin, are stored here, but not made here. That distinction will matter when we talk about diabetes insipidus and SIADH later. Some worthless knowledge moment: ACTH and MSH come from the same precursor molecule, the POMC. So when one goes rogue, the other sometimes tags along for the ride. All right, now let's talk about what happens when the pituitary gets a little too enthusiastic. Hyperpituitarism simply means excess secretion of one or more pituitary hormones. The key thing to remember is that the clinical picture depends entirely on which hormone is overproduced. Same gland, but very different outcomes. Most common cause is a functioning pituitary adenoma. These tumors aren't just sitting there, they're actively secreting hormone. Much less commonly, hyperpituitarism can result from pituitary hyperplasia or ectopic hormone stimulation. From a pathology standpoint, pituitary adenomas usually show fairly uniform cell populations. They're monoclonal tumors. Clinically, the mass itself can cause problems, such as headaches or visual field defects, especially bitemporal hemianopsia due to optic chiasm compression. And here's the irony. Even though one hormone is high, compression of the normal pituitary tissue can eventually cause secondary hypopituitarism. So you can have too much and too little happening at the same time, which equals endocrine chaos. Some worthless knowledge here is that pituitary adenomas account for about 10 to 15% of all intracranial tumors, yet most are benign, small gland, but extremely big personality. Now we flip the script. Hypopituitarism is defined by deficiency of one or more tropic pituitary hormones, and it most commonly involves the anterior pituitary. The key mechanism here is loss of functional tissue, not poor signaling, but actual destruction or damage. And this is important. Symptoms often don't show up until about 75% of the gland is damaged. The pituitary has a remarkable functional reserve. Early on, patients typically lose one or two hormones, not everything at once. Over time, additional hormone deficiencies may appear as damage progresses. Histology tie-in: by the time symptoms are obvious, the gland often looks fibrotic, ischemic, or replaced by tumor entirely. So the pathology reflects a long-standing process, not an acute one. Analogy: think of the pituitary like a lab with multiple instruments. You can lose one analyzer and still function, until suddenly you can't run anything. Let's talk causes, and this list explains why hypopituitarism is usually diagnosed clinically, not histologically. The most common cause is a non-functioning pituitary adenoma. These tumors don't secrete hormone, but they still take up space and compress normal tissue. Other causes include ischemic injury. Classic example would be the Sheehan syndrome. Surgery, radiation, trauma, hemorrhage, or inflammatory and infiltrative diseases. An important distinction: anterior pituitary dysfunction is far more common. Posterior pituitary dysfunction usually points upstream, toward like a hypothalamic lesion. Clinically, patients can have normal labs early on despite a growing mass. That's why diagnosis relies heavily on hormone panels plus imaging, not just histology alone. From a histotech perspective, by the time tissue is sampled, the functional story has often already played out. Sheehan syndrome is one of those conditions that perfectly ties anatomy, physiology, and pathology together. It's caused by ischemic infarction of the anterior pituitary during or after pregnancy, usually due to severe postpartum hemorrhage. Here's the setup. During pregnancy, prolactin secreting cells enlarge, increasing the size and metabolic demand of the pituitary. But the blood supply doesn't expand proportionately. So when massive blood loss occurs, perfusion drops and the gland infarcts. Clinically, patients present with failure to lactate, amenorrhea, and symptoms of secondary hypothyroidism and adrenal insufficiency. The mnemonic lamp fail helps tie hormone loss to symptoms. And yes, it's intentionally dramatic. Histologically, the gland shows ischemic necrosis and eventual fibrosis. But again, diagnosis is mostly clinical. Fun fact: Sheehan syndrome is now rare in developed countries, not because physiology changed, but because obstetrics improved. Pituitary apoplexy is the endocrine equivalent of everything just went wrong. It's an acute hemorrhage of infarction of the pituitary, most often occurring in a pre-existing adenoma. Sudden vascular compromise leads to rapid gland expansion, which explains the classic presentation. Sudden severe headache, visual disturbances from optic chiasm compression, and acute hypopituitarism, especially ACTH deficiency, which can be life-threatening. From an anatomic standpoint, the pituitary sits in a very tight space. When it expands quickly, it doesn't have anywhere to go except up or sideways, affecting vision or cranial nerves. This is a medical emergency. Without prompt intervention, patients can deteriorate rapidly. Histology may show hemorrhage and necrosis, but clinically this is diagnosed and treated long before tissue is ever examined. Analogy. Imagine swelling inside a rigid skull cavity. There's zero room for forgiveness. Before we get into specific tumor types, I want you to step back and think about location. The pituitary lives in a very small bony box, the sella turcica, and it has some very important neighbors. So when an adenoma grows, even a benign one, the biggest problem is often space, not malignancy. Think of the pituitary like a studio apartment in Manhattan. It doesn't take much clutter before everything around it is affected. As the adenoma expands, it can compress normal pituitary tissue, blood vessels, and most importantly, the optic chiasm, which sits just above it. That's why bitemporal hemianopopsia is such a classic exam finding. The tumor presses upward, pinching the crossing nasal fibers of the optic nerves. Histologically, there's nothing about a pituitary adenoma that screams, I cause visual loss. This is a great reminder that histology alone doesn't tell the whole story. Anatomy and growth pattern matter. Compression of normal pituitary tissue can actually shut down hormone production, leading to secondary hypopituitarism, even though the tumor itself is benign. Pituitary adenomas are the most common cause of hyperpituitarism, and they arise from the anterior pituitary, the adenohypophysis. These tumors are classified functionally, not by size or appearance alone. Function versus non-functioning. So functional adenomas secrete hormones and symptoms of access. Non-functioning adenomas don't. They show symptoms of compression. Under the microscope, pituitary adenomas tend to look monomorphic, so they have very uniform cells. They have round nuclei, and sparse cytoplasm, and a disrupted or absent normal acinar architecture. Compare that to normal pituitary tissue, which has a mixed population of acidophils, basophils, and chromophobes. Some worthless but useful knowledge: pituitary adenomas are usually soft and friable, which is why transsphenoidal surgery works so well. Surgeons can basically suction them out. Prolactinoma. This is the most common functioning pituitary adenoma, and it arises from the lactotroph cells. Prolactin is unique among pituitary hormones because it's normally under tonic inhibition by dopamine. That means anything that interferes with dopamine, such as tumors, stop compression, or certain medications, can increase prolactin levels. High prolactin suppresses the GnRH, which leads to decreased LH and FSH. Prolactin basically tells the reproductive axis, now is not the time. Some clinical manifestations, we'd have galactorrhea, which in non-lactating individuals. We'd have amenorrhea or infertility in women. There'd be a decreased libido and erectile dysfunction in men. Histologically, prolactomas don't look dramatically different from other adenomas. Diagnosis relies heavily on immunohistochemistry for prolactin. Very high prolactin levels strongly suggest a prolactoma, while mild elevations may just be a stock effect. Null cell adenomas are a classic example of why absence of evidence is still evidence. These are non-functioning adenomas. They don't secrete biologically active hormones and often show negative or minimal staining on immunohistochemistry. Patients usually don't show up with endocrine systems. They show up with headaches, vision problems, or hypopituitarism from compression. On H&E, you'll see sheets of uniform cells, but immunostains for pituitary hormones come back essentially negative, as you can see from the picture there on the right. The tumor is silent until it gets big enough to start knocking on walls. Mild hyperprolactemia may still occur due to stock effect, but this is not a true prolactoma. This is where pituitary pathology becomes systemic. ACTH secreting adenomas drive excess cortisol production by the adrenal cortex, resulting in Cushing's disease, not syndrome. Important to distinguish. Cushing's disease is the pituitary ACTH source. Cushing's syndrome is any cause of excess cortisol. Clinical features, we would have central obesity, moon faces, buffalo hump, and purple striae, which are stretch marks on your stomach, muscle wasting and weakness. Histology connection, these tumors arise from corticotrophs and often stain for ACTH on immunohistochemistry. Also, though, we see Nelson syndrome, which is a high yield concept. If both adrenal glands are removed to treat Cushing's disease, cortisol feedback is lost. The pituitary tumor can grow aggressively. Worthless but sticky knowledge, Nelson syndrome often causes hyperpigmentation because ACTH is derived from POMC, which also produces MSH. To this point, we've talked about pituitary adenomas in general. Now we're going to zoom in on growth hormone secreting adenomas, also called somatotroph adenomas. These are functioning at pituitary adenomas, meaning they actively secrete hormone, in this case, excess growth hormone, or GH. They are the second most common hormone secreting pituitary tumor, right after the prolactomas. Growth hormone itself doesn't do all the heavy lifting. Think of GH as the project manager. It tells the liver what to do. The liver then produces IGF-1, which is the hormone that actually drives bone growth, cartilage expansion, and soft tissue enlargement. A key concept here, and one that explains everything that follows, is that the clinical outcome depends on whether the growth plates are open or closed. Same hormone, same tumor, completely different disease. From a pathology standpoint, these tumors arrive from the somatotroph cells and are typically acidophilic on H&E, with strong growth hormone immunoreactivity on IHC. Let's start with acromegaly, which occurs when growth hormone excess develops after epiphyseal plate closure, meaning adulthood. Since the long bones can't grow lengthwise anymore, the excess growth happens in places that still can respond. So the hands, feet, jaw, skull, and soft tissue. This is why acromegaly is often missed for years. The changes are slow and progressive. Patients don't suddenly wake up with a new face. It's more like a time-lapse video playing at a quarter of the speed. Common features include enlarged hands and feet. Patients notice rings or shoes no longer fit. Prognathism and widening of the jaw, thickening facial features, and soft tissue enlargement of the tongue and airway, contributing to sleep apnea. Importantly, this isn't just cosmetic. Growth hormone and IGF-1 affect everything. So cardiomegaly, hypertension, insulin resistance, arthropathy from cartilage overgrowth. Some worthless but memorable fact, many patients with acromegaly are diagnosed by dentists or shoe store employees before they're diagnosed by physicians. This slide really drives home the concept of progressive change over time. You're looking at the same patient years apart. This is classic acromegaly. not dramatic overnight changes, but slow remodeling of bone and soft tissue. From a histology perspective, remember, the tumor itself doesn't look aggressive. The damage comes from chronic hormone exposure, not invasion. This is also why IGF-1 levels are so important diagnostically. GH is pulsatile and unreliable in isolation, but IGF-1 reflects long-term exposure, which matches what we see clinically. Now let's rewind the clock. Giantism occurs when growth hormone excess develops before epiphyseal plate closure, typically in childhood or adolescence. Here, IGF-1 acts directly at the growth plates, leading to excessive longitudinal bone growth. That's why patients are not just tall, they are proportionately tall. Clinical features include extreme height, early enlargement of hands and feet, acromegaly, metabolic complications like insulin resistance, and just like acromegaly, giantism is usually caused by a somatotroph adenoma. Histologic note, the tumor looks essentially the same under the microscope, same cell type, same growth hormone positivity. It's the timing, not the tumor, that changes the disease. It's one of my favorite endocrine slides because it perfectly captures how context matters in pathology. The same hormone from the same tumor type acting through the same mediator, IGF-1, and end up with two completely different clinical syndromes. The only difference is whether the growth plates are open. Think of it like pouring concrete. If the mold is still flexible, you get giantism. If the mold has already hardened, you get acromegaly. This is a great reminder, especially for us histotechnologists, that disease is not just morphology. It's anatomy, physiology, timing, and regulation all working together. Gonadotroph adenomas are actually the most common pituitary adenomas we see in adults, which surprises a lot of students because we don't talk about them as much. These tumors arise from FSH and LH producing cells. But here's the key idea. Most are clinically non-functioning. That means they may make hormone, but the hormone doesn't really do anything meaningful in the body. Because of that, patients usually don't show up with endocrine systems. Instead, they show up with mass effects, such as headaches are common, and if the tumor grows upward, it can compress the optic chiasm, giving us that classic bitemporal hemianopsia. Over time, compression of the normal pituitary can lead to hypopituitarism. So paradoxically, a tumor that technically produces hormones may cause hormone deficiency overall. Histologically, these adenomas are pretty bland looking. Uniform cells, not much drama. Immunohistochemistry will often show FSH, LH, or the alpha subunit, which is why pathologists can identify the lineage, even when the tumor looks silent clinically. A histology pearl here is bland, often equals benign behavior, but location makes it dangerous. Some worthless knowledge, most non-functioning pituitary adenomas are actually gonadotrophs. TSH adenomas are rare, but they're extremely important conceptually because they break the rules of endocrine feedback. These tumors arise from the thyrotroph cells in the anterior pituitary and secrete excess TSH. Normally, if T3 and T4 go up, TSH should shut off, but in this case it doesn't. So the lab pattern you see is the giveaway. Elevated T3 and T4 with an inappropriately normal or elevated TSH. That should immediately make you think this is not primary thyroid disease. Clinically, patients look hyperthyroid, so they have heat intolerance, weight loss, palpitations, and tremor, but they may also have headaches or visual changes from the tumor mass. These tumors are often misdiagnosed as Graves' disease or toxic nodules, which delays the correct diagnosis. Histologically, the tumor is composed of fairly uniform cells arranged in sheets or cords, and immunostaining is positive for TSH, sometimes along with other pituitary hormones. Teaching hook here is high T3, T4, and not suppress TSH equals a pituitary problem. So secondary hyperthyroidism does not always equal Graves. Keep that in mind as well. Up to this point, we've been living almost entirely in the anterior pituitary, which makes hormones locally. The posterior pituitary works very differently. The posterior pituitary doesn't synthesize hormones. It stores and releases them. Both ADH and oxytocin are made in the hypothalamus and transported down axons into the posterior pituitary. Because of that setup, posterior pituitary disorders are usually not tumors. Instead, they're problems of axonal injury or hormone dysregulation. There are really two big clinical syndromes to know here. Diabetes insipidus, where ADH activity is too low, or SIADH, where ADH activity is too high. Pathologically, damage to the posterior pituitary often means damage to the neurosecretory axons, not destruction of glandular tissue. A histology Pearl, posterior pituitary pathology equals axons, not endocrine cells. Diabetes insipidus has one of the most misleading names in medicine. It has nothing to do with blood sugar. DI is a disorder of ADH activity, and the defining problem is the inability to concentrate urine. There are two major types. Central DI occurs when there's decreased ADH production or release, often due to trauma, surgery, tumors, or inflammation affecting the hypothalamic posterior pituitary axis. And then there's nephrogenic DI, occurs when ADH levels are normal, but the kidneys simply don't respond. Lithium is a classic cause. Physiologically, patients produce large volumes of dilute urine, which drives intense thirst. If water intake can't keep up, patients are at risk for hypernatremia. Histologically, central DI is associated with loss of Herring bodies, which are the stored ADH granules in the pituitary. The overall pituitary architecture is often otherwise preserved. Clinical anchor, you pee too much and pee is dilute. So worthless knowledge, insipidus means tasteless, opposite of diabetes mellitus. SIADH, or syndrome of inappropriate ADH secretion, is essentially the mirror image of diabetes insipidus. Instead of too little ADH activity, we have too much. In SIADH, ADH is released inappropriately, even when plasma osmolality is low. This causes excessive water reabsorption in the renal collecting ducts. The key consequence is dilutional hyponatremia, not because sodium is lost, but because water is retained. Lab-wise, patients have low serum sodium, low serum osmolality, and paradoxically concentrated urine, all while appearing evolemic. Clinically, symptoms depend on how fast sodium drops. Slow drops cause mild confusion and headaches. Rapid drops can lead to seizures and coma. Pathologically, the posterior pituitary often looks normal because many cases of SIADH involve ectopic ADH production, classically from small cell lung carcinoma. Evolemic hyponatremia and concentrated urine is going to be kind of the big signal for SIADH. This slide is a great visual summary of what happens with antidiuretic hormone. ADH goes wrong in opposite directions. On the left, we have SIADH, which you can remember as being soaked inside. In this condition, there's too much ADH, so the kidneys keep reabsorbing water when they shouldn't. The body becomes diluted, especially sodium, leading to hyponatremia. Even though the person is retaining water, they don't usually look swollen. Instead, the danger is what's happening at the cellular level, especially in the brain. Water shifts into brain cells, which can lead to headache, confusion, seizures, and even coma if severe. On the right is diabetes insipidus, or DI. Think dry inside. Here, ADH is either missing or not working. The kidneys can't concentrate urine, so patients lose large volumes of dilute urine. The result is dehydration, intense thirst, and often hypernatremia if water intake doesn't keep up with losses. So even though both conditions involve ADH, they are complete opposites in terms of water balance and lab findings. Now we're shifting gears to the thyroid gland. Thyroid diseases are extremely common and show up frequently in both clinical practice and board questions. Broadly, thyroid disorders include hyperthyroidism, hypothyroidism, goiter, thyroid nodules, and thyroiditis. One of the most important clinical distinctions is whether the problem is primary or secondary. If primary thyroid disease, the issue starts in the thyroid gland itself. The thyroid produces too much or too little T3 and T4, and the pituitary responds appropriately by adjusting TSH levels. In secondary thyroid disease, the thyroid gland is structurally normal. The problem originates outside the gland, most commonly in the pituitary, leading to abnormal TSH secretion. Clinically, distinguishing between primary and secondary disease depends heavily on interpreting TSH in relation to T3 and T4. Let's review thyroid hormone physiology before we talk about disease. The thyroid gland produces T3 and T4, both made by thyroid follicular cells. Although T4 is the main circulating hormone, T3 is the biologically active form. Most T3 is generated in peripheral tissues by conversion from T4. Thyroid hormones increase the basal metabolic rate, increase oxygen consumption, and generate heat. They are essential for normal growth and central nervous system development, especially in infants and children. Regulation occurs through the hypothalamic pituitary thyroid axis. TRH stimulates TSH release. TSH stimulates the thyroid, and circulating T3 and T4 provide negative feedback to both pituitary and hypothalamus. Disruption at any point in this axis can produce thyroid disease. Thyroid toxicosis refers to the clinical state caused by excess circulating thyroid hormone, regardless of the source. The most common form is primary thyroid toxicosis, where the thyroid gland itself is overproducing hormone. Classic causes include Graves' disease and toxic adenomas or multinodular goiters. Less commonly, thyroid toxicosis can be secondary, caused by a TSH secreting pituitary adenoma. In this case, TSH levels are inappropriately normal or elevated despite high T3 and T4. Another important cause to remember is the excess exogenous thyroid hormone, often due to overmedication. Identifying the cause of thyroid toxicosis is critical because treatment strategies differ significantly. The signs and symptoms of thyroid toxicosis reflect a hypermetabolic state. Metabolically, patients often experience weight loss despite normal or increased appetite, and significant heat intolerance. The skin is typically warm, soft, and flushed due to increased blood flow and heat dissipation. Cardiovascular effects are especially important and include tachycardia, arrhythmias, and, if untreated, possible heart failure. Gastrointestinal motility increases, leading to frequent bowel movements or diarrhea. Musculoskeletal effects include proximal muscle weakness and muscle wasting, which can significantly impact the quality of life. Together, these features create the classic clinical picture of hypothyroidism. All right, now we land on Graves' disease, which is the classic cause of hyperthyroidism. Graves' disease is an immune disorder, meaning the immune system is the problem, not the pituitary. The key players here are thyroid stimulating immunoglobulins, or TSIs. These antibodies bind to the TSH receptor on thyroid follicular cells and basically act like a stuck accelerator pedal. Even though the pituitary is saying, hey, calm down, the thyroid ignores it and keeps pumping out T3 and T4. From a gross and histology perspective, the thyroid is diffusely enlarged and symmetric. Microscopically, you'd expect hyperplastic follicular epithelium, tall cells, scallop colloid. Everything screams overactivity. Now, the reason Graves gets special attention clinically is because of features you do not see in other cases of thyroid toxicosis, such as the bulging of the eyes, or otherwise called ophthalmopathy, pretibial myxedemia, which is localized dermal thickening of the shins. And then we have a fun fact slash worthless knowledge. The eye findings are not caused by excess thyroid hormone directly. They're caused by immune-mediated inflammation of orbital fibroblasts. So even if hormone levels normalize, the eye disease may not fully resolve. Lab-wise, this is classic. High T3 and T4, we have low TSH due to negative feedback. If you remember nothing else, Graves equals antibodies pretending to be TSH. Now we swing to the opposite end of the thyroid spectrum, hyperthyroidism, where everything slows down. Hypothyroidism is a clinical state caused by insufficient thyroid hormone, meaning low T3 and T4. Think of thyroid hormone as the body's metabolic thermostat. When it's turned down, all cellular processes run slower. The most common form is primary hypothyroidism, where the problem lives in the thyroid gland itself. The classic cause is autoimmune destruction, like Hashimoto thyroiditis, where the gland is slowly destroyed over time. Secondary hypothyroidism is less common and involves the pituitary or hypothalamus, meaning the thyroid could work, it's just being told not to. It's just not being told to. Sorry about that. Pathophysiologically, low T3 and T4 lead to reduced basometabolic rate, slower protein turnover, and decreased heat production. Clinically, this explains everything patients experience: fatigue, weight gain, cold intolerance, constipation, dry skin, and menstrual irregularities. The lab patterns here matter. Primary hypothyroidism, we will see low T3 and T4 and a high TSH. With secondary hypothyroidism, we see a low T3 and T4, but we see a low or inappropriately normal TSH. A histology tie-in here is that chronic autoimmune hypothyroidism shows lymphocytic infiltration, follicular destruction, and fibrosis, the opposite of Graves' hyperplasia. A mnemonic that still works: hypo equals slow, puffy, and cold. Slide is doing a lot of work for you visually, and I love it for that. Hypothyroidism and hyperthyroidism are physiologic opposites, but notice something important. They still share a few overlapping symptoms like fatigue and hair loss. That's why labs matter more than vibes. On the hypothyroid side, everything slows: cold intolerance, weight gain, bradycardia, constipation, depression. On the hyperthyroid side, everything accelerates: heat intolerance, weight loss, tachycardia, diarrhea, and anxiety and tremor. If you want a histotech-friendly analogy, hypothyroidism is like tissue sitting in under-processed fixative, sluggish reactions, and poor turnover. Hypothyroidism is like tissue that's been over-processed, brittle, stressed, and breaking down. Clinically, this slide reinforces why TSH is the screening test of choice. The pituitary is incredibly sensitive to small changes in circulating thyroid hormone. This is also a good reminder that thyroid disease is a spectrum, not a binary switch. Patients don't always read the textbook before showing up. And with that, we've reached the end of part 1. You've covered thyroid hormone synthesis and regulation, primary versus secondary thyroid disease, hyperthyroidism, hypothyroidism, and Graves' disease, and how all of this shows up clinically and histologically. If your brain feels a little tired right now, congratulations. That means it's working. In part 2, we'll pick back up once you've metaphorically wiped the drool off the keyboard, and we'll dig deeper into additional thyroid pathologies, structural lesions, and how these diseases matter in real diagnostic and laboratory settings. So take a breather, stretch, hydrate, and we will start part 2 once you wake up. Thanks.